We have the acute coronary syndrome. We have the two types. First one is the unstable angina or non-elevation myocardial infarction. The treatment that needs to be used is anticoagulation like heparin and antiplatelet therapy like aspirin. And there is adenosine diphosphate receptor inhibitors like clopidogrel. We also can use beta blockers, ACE inhibitors, statins, and also all of these medications. They deal with the end results of the infarction or angina. So they do change the course of the problem. But the nitroglycerin plus minus the morphine, whether we use them together or use one of those, they only deal with the symptom control. So they don't actually alter the end results. While these medications, they do change the outcome. So for the ST elevation myocardial infarction, we use the same exact medications that you used above, but in addition to that, most importantly, we're going to use the reperfusion therapy, and it can be done in one of two ways. Either it's the percutaneous coronary intervention, a surgical procedure that actually goes into the occluded vessel and try to open it, and it's much preferred over the fibrinolysis. That is the second option. It because the fibrinolysis may end up with some kind of hemorrhage at any other place other than the uh, heart itself. For example, we may have a stroke. So that's why the percutaneous coronary intervention is much preferred over the fibrinolysis. And it says here that if we have a problem regarding the right ventricle, for like there's a right coronary artery occlusion, in this case, we need to support the venous return slash the preload. Basically, they're the same thing because the preload is the amount of blood that is arriving to the heart in order to be pumped again into the systemic and pulmonary circulation. So we need to maintain the venous return and preload in order to maintain the cardiac output. And that may be done through the IV fluid supplementation and also avoiding nitroglycerin. So now for cardiomyopathies, we have three main categories. The dilated cardiomyopathy and hypertrophic cardiomyopathy, and then restrictive slash infiltrative cardiomyopathy. So for the dilated cardiomyopathy, it is the most common cardiomyopathy. So 90% of the cases of any patient with who has like cardiomyopathy, we would definitely put the first thing into our minds is just the dilated cardiomyopathy because it's most common. Well, there are multiple etiologies for it, so it could be idiopathic or it could be familial, and also it could be due to drugs or infection or ischemia, and also with systemic conditions or pericardium cardiomyopathy. So if you go a little bit into details, then it could be first idiopathic, second familial, and that is a mutation in the TTN gene that is encoding for sarcomeric protein titin. This deals well, the sarcomeric proteins, it seems like there are more than one. So the problem with dilated cardiomyopathy is just that it works with the titin. There's a problem in the gene encoding for this specific protein, and we're going to see that if we have a problem with some other proteins, we may have some other kind of myopathy like hypertrophic cardiomyopathy. But for now, the familial type of the dilated cardiomyopathy is related to mutation of the TTN gene. The other etiologies included drugs like alcohol, cocaine, and doxorubicin. So this is some kind of chemotherapy, and also infection like Coxsackie B virus or Chagas disease, which produces toxins. And also we may have ischemia like coronary artery disease, and also systemic conditions like hemochromatosis, sarcoidosis, and thyrotoxicosis or wet beriberi. All of these may be a good reason to develop dilated cardiomyopathy. And also we have uh, peripartum cardiomyopathy. As far as I think, this is related to prolactin, I guess. Anyway, so for the findings, there is heart failure, there is S3, and that is heard in early diastole, and also there may be systolic regurgitant murmur, Dilated heart on echocardiogram, because it's, well, if you take a look over here, then this is the posterior of the heart, this is the interior, and there you go, this is a dilated left ventricle when you compare it to the normal right ventricle. So and of course on chest x-ray it may look like as a balloon. So it's a balloon appearance of the heart. The treatment is sodium restriction, ACE inhibitors, ARBs, beta blockers, sacubitril, diuretics, mineralocorticoid receptor blockers like spironolactone and digoxin, and intracardiac device in heart transplant. So that's for the treatment. For basically the diabetic cardiomyopathy may end up as a systolic dysfunction. So it's a problem with the ejection of the blood to the outside of the heart during the systole. So this happens because the diabetic cardiomyopathy displays an eccentric hypertrophy, which means sarcomeres added in series. So if we think about it, the sarcomere are the basic point or element in creating the muscle. So this is a cardiac, a normal cardiac muscle, and sarcomeres. Each one of those that I just draw it are sarcomeres. So now in diabetic cardiomyopathy, we're going to have more sarcomeres, but in this case, they're going to be added in series. So they just come one next to each other in series. So that's how we the addition of sarcomeres, and that is going to be different from the concentric hypertrophy that we're going to get to in a minute. So because they're in series, we can compare this to the athletics hearts, because in athlete's heart, there is the left ventricle and right ventricle. They may enlarge in order to facilitate the increase in stroke volume and increase in cardiac output that the athletic body needs, because they, of course, they need more blood going into the vital organs and muscles and everything. So they need higher stroke volume and higher cardiac output. That's why in athletes we have an enlargement of the left ventricle and right ventricle. So, and that is something to compare with the eccentric hypertrophy of the diabetic cardiomyopathy. We have something here that is the stress cardiomyopathy. It is also called Takotsubo cardiomyopathy. Guess that's Japanese. Not sure. It is basically a broken heart syndrome because there is no actual something. There's nothing physical with the heart, like an actual problem, but it may end up and look like as a ventricular apical ballooning, but that's due to increased sympathetic stimulation. So it's mainly due to sympathetic stimulation, not like atherosclerosis or embolus or anything like that, and that's why it's considered not temporary. It's considered temporary, not permanent at all, just like stressful situations. And something like that came in your world, saying that there's an old female who has like angina like symptoms, and but she then it all went away. That happened after her husband died 2 days ago or something like that. So basically it's just because of the stressful situation all of that is happening, and it completely resolves. For the hypertrophic cardiomyopathy, 60 to 70% of these cases, like of the cases of hypertrophic cardiomyopathy, are familial. So if we take a look and about okay, familial, yes. So they're basically familial. Let's see if we have any other reasons. Okay. Now, it doesn't mention anything here, but that means also emphasizes about how important the familial side of it is, because 60 to 70% of these cases of the hypertrophic cardiomyopathy are familial, and the mode of inheritance is autosomal dominant. Most commonly, most commonly, not always, but most commonly, due to mutations in the genes encoding sarcomeric proteins, just like myosin binding protein C and beta myosin heavy chains. So this is a different kind of proteins that are related to the sarcomeres. So they are sarcomeric proteins, just like the myosin binding protein C and beta myosin heavy chains, and that is different from what we have talked about over here. That was a problem with the sarcomere protein titin. Okay, so the hypertrophic cardiomyopathy causes syncope during exercise and may lead to sudden death. That's something we see in young athletes due to ventricular arrhythmia. So this um, hypertrophic ventricle may end up as arrhythmia and also sudden death, and that is quite common in young athletes. That's something to pay attention to because that comes in the tests a lot. It's sudden cardiac death in athletic patient or patient who's doing some physical activity, like a tough physical activity. For the findings, we may find S4, and that is to be heard at the end of diastole, and systolic murmur, of course, may see mitral regurgitation due to impaired mitral valve closure. The treatment is cessation of high intensity athletics. Of course, that needs to be stopped. The high intensity athletics. Also, we can use beta blockers or non-dihydropyridine calcium channel blockers like verapamil, and also intracardiac devices if the patient has a high risk for the problem. Also, we need to avoid the drugs that decrease the preload, because if you think about it, what we have in this condition is there is like a hypertrophied ventricle. So this there is the lumen is really tiny. It doesn't allow for a lot of blood to be filled in here, so not a lot of blood is allowed to go from the left ventricle into the systemic circulation. So we definitely need more blood. So we cannot restrict the amount of blood that is coming into the left ventricle because we need the amount of blood that is leaving the left ventricle to be enough. So we need to avoid the drugs that decrease preload, like diuretics and vasodilators. Both of these, they decrease the preload, which means they decrease the amount of blood going back to the heart, and the amount of preload is too little. That means the heart does not have too much blood to pump. So that is not good to do because we already have uh, um, a hypertrophied left ventricular muscle and also a smaller lumen that does not contain a lot of blood. Here it ends up as diastolic dysfunction. So the problem is with diastole. So it's not with the ejection of blood, but it's with the um, elasticity or the capacity of the relaxation of the ventricle. So in this case, what we have is the addition of sarcomeres in parallel. So it's concentric hypertrophy. So if we draw again the sarcomeres, they are the basic elements in the um, muscle in the myocyte. So if we add the sarcomeres in this case in the hypertrophic cardiomyopathy, they're going to be in parallel. So 1/1 over 1 over 1 over 1. So it's not in series as we've seen here. So this is the parallel. This is what's called concentric hypertrophy. And often it's septal predominance because these may be added predominantly in the septum, in the interventricular septum. So it's not like organized. That's why we see myofibrillary disarray and fibrosis. This is classified, okay, and this condition may also be classified as hypertrophic obstructive cardiomyopathy when the left ventricle outflow tract is obstructed. So this can be also obstructive, like hypertrophic obstructive cardiomyopathy, because sometimes the due to the septal predominance or the addition of sarcomeres in any place leads to obstruction of the blood going out from the left ventricle into the systemic circulation. And this is something we see here. It says like asymmetric septal hypertrophy and also systolic anterior motion of mitral valve. They both lead to outflow obstruction. And of course, that means dyspnea and possible syncope because blood is not going as much as needed. So, other causes of concentric left ventricular hypertrophy, some other cases that do have the sarcomeres to be added in parallel, as in here, is the Friedreich ataxia and the chronic hypertension. So, chronic hypertension and Friedreich ataxia both have concentric left ventricular hypertrophy. Okay. Now, for the restrictive infiltrative cardiomyopathy, some of the examples are uh, post radiation fibrosis and Loeffler endocarditis, endocardial fibroelastosis, and that is the thick fibroelastic tissue in the endocardium of young children, probably from 1 year to 2 years old babies. There is a deposition of fibroelastic tissues in the endocardium of these children. That is called the endocardial fibroelastosis, and it's considered restrictive cardiomyopathy, or we may also say it's infiltrative cardiomyopathy. Also, some other condition is amyloidosis, considered an infiltrative cardiomyopathy, also sarcoidosis, hematochromatosis, and to memorize it, it just says, please help. So, what happens here is there is also a diastolic dysfunction. So, a problem within the diastole, not with the ejection of blood outside the heart. So, in this case, we can have low voltage ECG like the P, Q, R, S. Okay, that's crazy. Okay, P, Q, R, S. T. So the elevation of the QRS complex is not gonna show like tall as it's supposed to be. It's gonna be less than that. That is considered low voltage. So even though we have a thick myocardium, actually, because in the restrictive infiltrative cardiomyopathy we do have thick myocardium, but even though it doesn't show clearly on the ECG, and we're going to get a low voltage ECG. So, and this happens especially in amyloidosis. Okay. So, for the Loeffler endocarditis, it says that is associated with hypereosinophilic syndrome, and histology shows eosinophilic infiltrates in myocardium. So, Loeffler syndrome basically has, just like the endocardial fibroelastosis, it has a lot of elastic tissue depositing in the myocytes, but in addition to that, mainly we see eosinophilic infiltrates in the myocardium. That's how we know it's Loeffler endocarditis. And that should be it.